my sexual health.
You need to unmute yourself.
Yeah.
There we go.
Well done.
Yeah. Okay.
Well, we're going to spend a few hours over here, and I'm sure that when we finish here, Steve, we can go home unimpeded by taxis. Presentation this afternoon is Sex and the Menopause, and that's by Dr. Elna Rudolph. I heard her speak at the menopausal meeting. You were there too, Steve.
Yeah.
You heard her speak as well.
That's fantastic.
Yeah. And it's actually sponsored this afternoon by Stellis. For once, we won't be playing out of the video, so I'll just thank them in advance. Thank you, Stellis. Now, second, of course, is the floor. The other thing is a big thank you. Corin, as you know, is the setter-upper of everything. Now, Elna Rudolph is going to be thanked by Steve at the end, and I'll just say a few things. At the present time, Dr. Rudolph is the clinical head of My Sexual Health, and that is a special...
Is that what the MSH stands?
My Sexual Health.
Oh.
Yeah.
Other
No.
people's, not
No. She's president of the World Association. I told you, Steve, no jokes. She's president of the World Association for Sexual Health, and she's also a host of a popular television program called 80 Slaapkamer. Did you know that, Steve?
Yeah.
Yeah.
Ek het nooit gekyk nie.
Okay, there's something to do at night. So she's obtained a master's degree in sexual health. There she is. She's obtained a master's degree in sexual health through the University of Sydney, in Australia. And she's one of the very first fellows of the European Committee for Sexual Medicine. So she's an extremely well-qualified person to speak on the topic of sex and the menopause. And she's only the second woman and the first person in Africa to be president of the World Association of Sexual Health. So there is, I can think of no better qualified person than Dr. Elna Rudolph for presenting sex and the menopause. And very briefly, next week, we have individualization of hormone therapy in medicine. And that's going to be produced by Dr. Percy Moodley. It's also sponsored in that time by Abbott. So without further waste of time,
Hello. Thank you so much for having me, guys. Sorry, I think someone tried to phone me and that made my my signal dip for a while. You guys look like sex talk show hosts, I must say, sitting there closely together and running this thing. So thank you so much. I
Oh,
feel quite
good.
comfortable
The shirt.
to be introduced by you. I thank you to all of you for being here this afternoon. You know, time is the most valuable resource that is completely unrenewable. So the fact that you're here to spend it with me and listen about sex in menopause, I hope that it is partially for yourself, and it's great that it is also for patients. Now, just I hope that my signal isn't hanging like I can see it is from that side. Karen, if you can maybe
Do you
just
have
let me
load
know if my
shedding there,
signal is
Elna,
fine.
or is it not a problem? Okay, there's
Your
no load.
signal's coming through fine.
Yeah.
Okay, great. Okay, let me share my screen here and then I'll get going from my side. So, sorry. Slideshow.
You would just click on yeah, that's it.
There
That's
we go.
exactly.
Yes.
You know.
Okay. So I'm from My Sexual Health, and we are a group of credible sexual health providers. And this really changed. You know, I studied medicine in South Africa 20 years ago, and was it 20 already? Something like that. And at that time, Etienne Cook was training us at Tux, where I studied, and he was one of the only really a handful of people that had the opportunity to go to America at that stage to go and get training in sexual health. But subsequently, more of us have been able to venture out and go and get international training. And now it's possible, due to what we can do online, to actually train up credible sexual health providers without all of them necessarily having a master's degree in sexual health, but actually having a lot of know-how. So we were trained that, you know, like, you can't really treat low libido. Nonsense. There's ample research on how to treat low libido, and on every other thing regarding sex that you can imagine. So we firmly believe in evidence-based medicine. So if you refer a patient to someone that associates with the My Sexual Health team, you can know that they are credible, they've got proper training behind them, they work in a multidisciplinary team, they work under supervision. All of them have to work under clinical supervision, and the supervisors have PhDs in sexual health. So it's really not, you know, like the local guy who's actually interested in porn and now calling himself a sexologist anymore. So I'm the co-owner of My Sexual Health, and we do sell sex toys and stuff, which I'm going to show you some of here tonight. But honestly, we're not the biggest online sex store. There's lots of places that you can refer your patients to. And then, you know, evidence, when you talk about sex toys, for instance, is it evidence-based? So everything we do, everything we teach each other in our group and also globally is about being evidence-based. But there is a strong part of it that's actually experience informed. If you've seen 1,000, you actually know what to do. So a part of what you see here is the experience formed part of it, and not specific advice for any patient. And if you don't feel comfortable to treat a person with anything sexual or any other thing, you refer to someone that you think is more capable of doing so. So in sex therapy, you always do a location of self, because inevitably there are so many things in you that's different than in the patient. And this is my location of self. Now you can imagine, in my role as the president of the World Association for Sexual Health, I am frequently in environments where people are not like me at all. And I kind of out myself as a cisgender, heterosexual, vanilla, allosexual, married and monogamous, white African, and that I'm privileged and a Christian as a sexologist. Have you ever? And also, as I said, you know, science-based doctor, and I volunteer as the president of WAS, and I'm a mom. So your menopausal patients are not all cisgender. You might see a trans woman who has a penis and who has a prostate. And you will see a guy in your office who has a beard and Adam's apple, but he has a uterus. So not all of your menopausal people will be women necessarily. heterosexual. Of course, not all menopausal people are heterosexual, and not all of them are vanilla. Some of them are pretty kinky. And allosexual means that you do have the ability to experience sexual attraction, as opposed to asexual, not having that ability. And when we talk about menopausal women, we have to acknowledge that most of them, almost all of them, are allosexual. Although they're menopausal, they probably still have the ability to experience sexual attraction. And they would love for their partners to find them sexually attractive, although they might have gone through lots of self-esteem stuff in menopause, with weight gain, with sagging, with a loss of sense of self, or the opposite. They might, now that they are becoming older women, for the first time in their lives, actually get into themselves and really enjoy the fact that they have this maturity, and start enjoying their sexuality much more than they used to do. And we know from the research that many people have the best sex of their lives in their menopause. Many people stop having sex in menopause, by choice or not by choice. So on the one hand, don't forget that your menopausal patients are sexual beings. And on the other hand, don't sexualize all menopausal patients. Not everyone that comes in there with a dry vagina has a problem with their vagina being dry, although, as you very well know, dry vaginas are not only about sex, it's also about incontinence and recurrent UTIs and just discomfort in general, as we know through the genitourinary syndrome of menopause. So, of course, not all of your menopausal patients are married and monogamous. I cannot tell you how many sexually transmitted infections I see in menopausal women or people of advanced age. People get divorced, their partners die, they are no longer with the same partner that they fell in love with at university. And some people walk around with the syphilis that they picked up in the army, and it's just never been tested. And some pick up chlamydia from the guy that took them for dinner last week. So it's important to still have conversations about safe sex with menopausal women. And it's a bit awkward, right? Because you do not want to go and make menopausal women think that you judge them for possibly being promiscuous. But on the other hand, if they are not in a monogamous relationship, if they are dating again, they definitely at risk for picking up STIs. And then, of course, we all treat different cultures, and how sex is seen in each culture is really quite sacred and different. And even within cultures, there are so many differences, but you can rest assured there's actually many, many more similarities than differences. So don't be too afraid to broach the subject of sex, even with someone that's from a different culture than you or a different religion. Okay. So this is when I am in my role as the president of WAS. You can see all of these different cultures coming together, and we negotiate things, and we try and make the world a better place when it comes to from a sexual health perspective. And you know, there are really, really serious things from a sexual health perspective. There's child marriage, there's genital mutilation, there's the fistula that you guys often deal with. There is gender-based violence, and just weirdly, so at WAS recently, we've been focusing on pleasure. And I'll explain to you how and why shortly. So if you look at sexual dysfunction, especially as it is associated with the menopause, any kind of condition, any chronic condition, you can actually look at sexual dysfunction from this perspective. There is a primary dysfunction, and that's a dysfunction caused by the physiological changes of menopause. And it is dysophytosecui. There are definitely physiological changes that cause sexual dysfunction in menopause. Then there's a secondary dysfunction that's caused by the medical treatments. Many menopausal women are on treatment for cardiovascular disease, diabetes, they're on psychiatric medicine, they've developed cancer, and all of these treatments can also cause sexual dysfunction. And then the tertiary sexual dysfunctions are caused by the psychological impact of being in menopause. And any women sitting in front of you might have a sexual dysfunction on any of these three levels, or all three of these levels. So the traditional approach of the great healthcare provider to sexual dysfunction is to say something like this: women in menopause often have problems with sex. How about you? Every single woman that you see in menopause, even if you're a guy, even if you are much older or much younger than that person, every single woman has the right to hear this statement and question from her healthcare provider. You are the powerful person in the room. It's your obligation to make the statement and ask this question. Women in menopause often have problems with sex. How about you? So it's same goes for pregnant women often have problems with sex. Breastfeeding women often have problems with sex. Women after pelvic surgery often have problems with sex. Incontinent women often have problems with sex. How about you? So you just make the statement and then you open it up to the patient, because you just doing that tells that person that you are a safe person that they can bring their concerns to. Are you equipped or willing to sit and talk to them about it for an hour? Maybe, maybe not. And if you're not, there is now a way for you to refer those patients to someone that is perfectly happy to do so. So if we look at sexual dysfunction in 2023, basically, this is what we are sitting with. So this is now you've asked them, how about you? And now they start talking about what their problems are. So let me just put it on the table, what the current problems are. So hypoactive sexual desire disorder, very, very, very well described condition. You can easily diagnose it through a questionnaire. My favorite questionnaire is the FSFI, Female Sexual Function Index, because you diagnose desire, arousal, orgasmic, and pain disorders all on that questionnaire. One questionnaire that the patient can easily complete even before they see you, which is advisable. So this is now the old low libido, but in 2023, we don't actually talk about low libido.
Sorry, Elna.
Yes, yes,
Can
yes.
you just tell us the name of that questionnaire again, slowly?
FSFI, Female Sexual Function Index.
And where do we get that particular? Is it downloadable somewhere?
Yeah, there's lots of downloadable versions of it available now. I put mine on JotForm. You can put it on a free JotForm. I don't think Google Form is secure enough. And then my patients complete it before they see me. So when I see them, I already have the result of the FSFI. And then you can make a diagnosis of global sexual dysfunction. If the score is under 24, you get like, oh, there's probably problems here. And if it's above 24, there's probably not significant sexual dysfunction in this patient.
Okay, thank you.
If you give me a minute after I'm done, I'll share a link to it.
Thank you so much.
Okay, so today we talk about desire discrepancies in patients. And look, I'm very passionate about this because I see so often how women are being dragged in by the collar into my office to sort out her libido. But can I tell you, half of the people I see in my practice with low libidos are men. Many menopausal women, like the lady and gentleman that I spoke to from Uppington just now before this webinar, where she still wants to have sex. She's in her 60s, he's in his 70s, but he's not interested anymore and he can't perform, which is also a problematic work. Anyway, the relationship has a problem and there's a desire discrepancy in the relationship. Do not pathologize the women with the low libido. The problem is that the two of you are fighting over how much sex is normal for us, and how can we then as healthcare providers help you to better figure out what would work in that relationship. Yes, can we maybe up the one's desire? Can we maybe lower the other's desire? Or maybe it's not necessarily a 50-50. Maybe we need to look at the context and all kinds of other things. So the new buzzword is desire discrepancy, not low libido. Then you get arousal disorders. And the actual thing, what we talk about nowadays is arousal non-concordance as opposed to arousal disorder. So the old way was saying the person has a objective or a subjective arousal disorder. And this is something that you hear. Menopausal patient yesterday, she hates it when her husband puts his finger into her vagina. She just doesn't like the feeling of that. And then his response is, but how must I know if you are wet? He's menopausal. So his assumption is, if I put my finger in there and you are wet, it means that you are ready for sex. And that is bull, complete bull. Women get wet without being ready for sex. And women are hell of a ready for sex without being wet. Okay, so wetness is not an indication of whether you're ready for sex or not. That is arousal non-concordance. There's actually shockingly poor concordance between what women feel in their brains. For instance, watching monkeys having sex and getting wet and really feeling like I'd love to make love to this person now, but I just do not lubricate. So don't pathologize women around their wetness. Let them use a lube if they're ready for sex psychologically, but just do not have enough lubrication. So how does he know whether she is wet or not? He asks her if she's ready for penetration. Does she want penetration now? He does not have to stick his finger in there. Okay, then the second one around that is persistent arousal, genital arousal disorder. So that's, again, also much more common as women enter into menopause. Some men also suffer from this. So this is a feeling of actually feeling aroused. People commit suicide over this. They feel aroused to the point that they actually sometimes have spontaneous orgasms, but it's a genital arousal and they're not psychologically aroused. They're not ready for sex. They're not in a sexual situation at all. They're in a meeting and they'll orgasm. The first patient that I saw like this was like the most typical Afrikaans university professor in her mid-60s, and she was having spontaneous orgasms at work. So, okay, that is the latest on arousal disorders. Then you get orgasmic disorders, and you get delayed orgasm, anorgasmia, and then post-orgasmic illness syndrome. Also, in the menopause, as the physiology changes, this happens. Women feel sick after they've had an orgasm. Obviously, it can happen to men as well. But this is not just like, oh, I don't really like sex because I'm a bit dry. This is, I feel sick when I've had menopause, and I can maybe feel sick for a day or up to a week afterwards. And there's various treatments for that. And then, of course, as you guys know, genitourinary pelvic pain or penetration disorder. So this is the old vaginismus and atrophic vaginitis, and all of those things are now put under this category, and genitourinary syndrome of menopause is certainly one of those. And then vulvodynia, secondary vaginismus, which you see in menopause, where women maybe had a trauma as a young person or as a child, then we're okay. But now that they're dry, or now that they're struggling to become aroused, now the vaginismus is triggered again. Or pelvic floor hypertonicity. So we're always worried about older women's pelvic floor sagging and becoming weak and the incontinence associated with it. But if you ask me, older women have a hell of a tight pelvises, because those are the ones I see, the ones with the sexual pain. They have a hypertonic pelvic floor. And then there's out of control sexual behaviors. And it's not that common in women in menopause, definitely not, but it can still happen. There's the paraphilias, there's addiction, there's women in menopause that are exposed to gender-based violence. And what I see particularly is men that develop dementia. And then the woman actually gets in a loving, safe relationship, now exposed to gender-based violence because of their partner's dementia. And there's still some body dysmorphic disorders floating around in menopause as well. Okay, so now you hear, I mean, it's quite complicated, and there are standardized questionnaires to diagnose each one of those conditions. So if you ask women in menopause often experience problems with sex, how about you? And then they start talking about their persistent genital arousal disorder, it might be quite overwhelming. I mean, if you think, the worst thing that can happen there is she will tell you, doctor, you know what, actually what happens is I get spontaneous orgasms, and you go, wow, lucky you. Because we can sometimes be like really condescending towards our patient's sexual problems. The amount of times that I've been told that a doctor has told a patient to have wine and just relax, or, oh no, your sexual problem is only in your head, is really, it's fascinating. And yes, it is in your head, but there's a really serious, seriously complicated neurochemistry happening in the head that is playing a role here. But many of those things can actually be altered, but patients need professional help to do so often. Otherwise, they won't be in our rooms if they could figure it out themselves. So there's a beautiful new definition of sex, and that is a sexually pleasurable activity shared affectionately amongst equals. And I just love, it's Ellen Lahn, who was a world famous sexologist. She recently passed away, and her last paper, this definition came out of there. And if you think of the traditional heteronormative way of thinking about sex, where it's a rock hard penis that goes into into a vagina and then both must have orgasms and that's pleasure. If that's your view of sex, what a shame. It's such a limited idea of what sex can be. Sex is all of those, or all of these things, of which that is maybe just a little bit. And if we don't encourage patients, if we don't encourage ourselves to expand our repertoires of what sexual pleasure can be, then we are also going to limit our patients' ideas of that. So if this vagina has shrunk and is dry and a penis is not fitting in there anymore, then it does not mean that she can't experience sexual pleasure. She can have fantastic sex. She can have amazing orgasms without that being necessary. And when I'm saying this, I'm not talking about threesomes and porn and vibrators, really. In my journey now in working with sexual pleasure with the World Association for Sexual Health, I realized that, what beautiful pleasure there is from my husband just having his hand on my hip. That's sexual pleasure. That look that you exchange with your partner, that knowing look, I mean, not a horny look, just like a connection look, that's sexual pleasure. So if we don't give our patients the opportunity to expand their repertoires and have this very limited idea, and you guys deal with diseased pelvises all the time, a diseased pelvis cannot always accommodate a penis. And but they can still have very, very pleasurable sex or experiences. So why is sexual pleasure important, politically important? Sexual pleasure helps to cement the kinship structure of the couple relationship and contributes to overall happiness in people's lives, whether they are in partnerships or not, and is associated with aspects of overall health. So if you improve the kinship of relationships, you improve the community. And if you improve the community, you improve the place that we raise our children and that our elderly people grow old in. So it really plays a big role. These people got together. They're from the World Association for Sexual Health. If you're a sex nerd like me, you recognize all of their faces. They're really influential researchers that got together and produced this declaration, which is the Declaration on Sexual Pleasure. And I love to have time to read it to you as if it is an erotic poem, but we don't have time for that. And it's quite a political document. What's important for healthcare providers in here is basically just the one sentence that says we have to create enabling environments for sexual pleasure as healthcare providers. So there's a technical document behind it. And then this is the article that Alan Lane was the main author of. And this is available open source. If you read only one article about pleasure in your life, read this article. And it's about the pleasure gap. And what is so beautiful about this is women are 100% biologically equally able to have sexual pleasure. So the old notion was, men can get erections so easily. Men always think about sex. Sex is much better for men. Nonsense. If you look at it biologically, women are equally as capable of pleasure as men, but there is a massive pleasure gap. Women often have much more dangerous sexual experiences where they feel threatened during the sex. They often experience violence. They're 5 times more likely to experience pain in their pelvises. So the pleasure often comes at a greater cost for women, but that's a very interesting article. So how do you go now and clinically apply this? So now, hopefully, I have passionately convinced you that pleasure is actually important in menopausal women, but now how do you go and put this into your practice? So you have to do it ethically, because if you're just going to start having sexy talk with your patients, that is a big problem. It's completely unethical to obviously get physically involved in your patient's pleasure, or to, just like you don't engage in sexy talk with patients. So how do you do it as a professional? With any consultation around sexual health, there's this very specific, very well-researched model that's used internationally. I just wrote a paper for the International Journal of Sexual Medicine, again, based on this model. It's so simple and applicable to any sexual health interaction. So it is permission. The very first thing that you need is permission to talk about it. Then you give the patient information, and it used to be limited information, but I think limited is not good enough anymore. We live in the information era. We cannot give our patients limited information. That's old kind of doctors that, you know, I just tell you what you need to know kind of thing. We are now in an era of informed consent, of shared decision making. So we need to give our patients proper information. Then we give them specific suggestions, and then intensive therapy to those who need it. And for that, you might want to refer. So the first principle of permission is, how do you as a healthcare provider have permission to talk about this? You're a gynecologist or a doctor or a nurse. You've already have the permission in your profession to talk to people about their sex lives. Believe me, even if you don't have any additional training. But if you look at the ethical principles for people working in sexual health, we do encourage people to have appropriate professional preparation. So on top of your healthcare provider qualification, and that's why we're so adamant that people that are not healthcare providers shouldn't be sexologists. You need the ethics behind being a healthcare provider to be a sexologist. So for instance, what we do at My Sexual Health, this is a CPD accredited, something probably 60 to 100 hours of sexology courses put together in a bundle. So as a doctor or as a GP or a gynecologist or whatever specialization you are, you can do an online course. And these are multiple small online courses that you can do in small chunks. Then there's the sexual attitude reassessment process that is extremely valuable. This was now the advertisement of last year's one. The Southern African Sexual Health Association does one every year. There will be one this year in October again. And this is just where your own attitudes towards sex is evaluated and you're helped to not be judgmental of what other people do. It's not to change your own values. You know, we're very adamant that that's why I say I always come out as being monogamous, because people assume that people who are woke when it comes to sex, you know, must be polyamorous to be woke. No, your values are very important, but you just don't go and portray or enforce your values onto your patients, which is such a basic principle we all learn in medical school. Okay, so then ethical curiosity. When you start talking about to sex to patients, it might become really interesting to you, and but you have to limit the questions that you ask to only that which the patient is willing to share with you. And this is, I mean, please don't try and read that old slide, but the point of it is you ask a person. So as I said, if you just ask them that first question of people in menopause often have problems with you, with sex, how about you? It's already much better than nothing. But the more academically correct way to do it is to say, are you, if you don't mind me asking, are you sexually active? Then in other, I mean, I wouldn't say with yourself or with other people. I won't just say that to a South African menopausal woman. There's not one I will say that to. I'll just ask, if you don't mind, but yeah, if you don't mind me asking, are you sexually active? And then if they say no, you ask them, is it by choice? If they say yes, you say, okay, cool. It's by choice that you're not sexually active. If you ever want to discuss anything about that with me, you're welcome to do so. And you move on. If they say, no, it's not by choice that I'm not sexually active, then you say, would you like to discuss it with me? And then they can say yes or no. And again, you can encourage them that they're welcome to talk to you about it. If they say yes, they're sexually active, you ask them if they're experiencing any problems with their sexual function or ability to experience pleasure. Just add that in there. And then again, you know, it's a yes, no, and you go further as the person allows you to. And most often, I mean, I'm a sexual health provider, so people come there knowing that that's what they're going to talk about. When they go to you, they will also probably be a little bit surprised that you raise the subject, but pleasantly surprised. The research shows over and over that they want, 80% of patients want you to raise the subject. And if they don't want to, they can just say no, you know, and never talk to you about it again. And then at least you know that you have raised the subject with them at least once. Please, I hope I spoke by you to do it one day from tomorrow. So alternatively, if you don't follow that process where you basically open it up to the patient to bring things to you, you're in a position where you now need to go and screen for all of those complicated things that I referred to earlier, which you're not going to do. I mean, this is, each one of these things I mentioned here is at least an hour consultation on its own. So just put it on the table and find out if there is anything, and then you can schedule another appointment to address it or refer the patient. So the enabling, yes.
So, although I think obviously one of the big issues is really that we might be a little bit maybe nervous about what answer you might get from the
Yes.
from the patient, and then and often people are tight, the schedules are tight, and then you're opening up
Yeah.
a thing that needs to be addressed. So I
Yes.
suppose that's really one of the big challenges in in gynecology particularly, maybe in GP stuff as well. But
Yes.
yeah, I don't know how you-
Yeah, the worst is when they were walking out the door and they grab the handle and say, "Oh, by the way, I
Yes.
promised the libido," and then you're going to start again. Usually, I
Yeah.
guess, Steve, you would say, I'd like to share that option you raised. Can we do it perhaps at our leisure? Because you can't do it in 2 minutes or 5 minutes.
No.
If you're in a hurry.
Yes. Yeah.
So it'd be better to reschedule at your own leisure,
Yes.
at her own leisure, so you don't have
Yeah.
to rush. And then
Yeah.
she'll
Yes.
feel afgeskipt, as you would say. I would feel
Yeah.
ambushed, and
Yes.
no one's happy with that consultation.
No. But you know what changed now in the last few years, I really believe, is the fact that and look, you might think I'm touting for patients here, but I'm not. I would you know what it's like when you feel like you want to run away. But there, if you tell a patient that, you know what, sexual health is not my specialty at all, but there's actually a group of people that really specialize in this, and they see people online, go and check out my sexual health's website and look for someone that it looks like you will be able to relate with there, then you've already helped that person. And there's actually also research to show about that, to show that if a person perceives their doctor to have made a good referral, they think the doctor was great. I mean, you guys are super specialists in what you do. So your patients that you see, you don't see many of them primarily. Many of them come to you because their gynae told them to see you, or their GPs. And they love their GPs and gynaes for the fact that they send them to you, because you guys are super specialists in what you do. And they don't think, oh, my stupid GP couldn't deal with my pelvic floor. They respect that. So we had big problems in South Africa where it was impossible to refer your patient with sexual stuff. And also it was kind of untreatable. Now we've got such a long list of evidence-based treatment for sexual dysfunctions, but you just have to know what the diagnosis is to be able to prescribe it to your patient. So I think my take-home message is really refer. And you don't have to be inside as I said, we're 58 people on our multidisciplinary team. You don't have to be inside the team to make a good team referral, because I mean, you will also get your feedback even if you're outside of the team, and the patient gets sorted, just like the way that you guys work. So I think referral is the answer.
Thank you very much.
But on the one hand, on the other hand, I do think every person on this call have the ability, with not massive amounts of extra training, to be able to deal with it themselves. But you need to have an interest, number one. And number two, you need to actually make the time. You're not going to deal with a sexual dysfunction in 15 minutes. You're never going to. So you then need to say to your receptionist, Wednesday afternoons, leave the last 2 hours for me open, and then schedule our consultations. And you don't do that for money. You can never make money out of that. You do it for the love of the game, then, if that is something that you're interested in. The more you do it, the better you get it, and the more comfortable you get.
Thank you.
So sorry, let me now start sharing again. Yeah. Okay. So the enabling factors for pleasure, you would think that it is like owning a vibrator, but actually there's good research about this as well. And that is that pleasure is self-determined. That thing about the one partner being dragged in by the collar because they can't orgasm, pleasure is self-determined. So the menopausal woman who has a problem with sex, you have to make sure that this is something that she really wants to fix for herself. Yes, the partner can benefit from it. Yes, the relationship benefits from it. And if that happens, she also benefits from it, but it is self-determined. She needs to be in a position where she can negotiate consent. If she cannot say no without any consequences, she cannot really say yes. Is she safe in that environment? Do they have the privacy? And privacy becomes more and more of a problem as people age, living with family and in old age homes. Confidence, that she have the confidence to ask for what she wants and confidence to say, listen, that is actually painful, please don't penetrate tonight. Or does she have the ability to communicate and the ability to negotiate? And then an enabling factor for sexual pleasure is health. Overall health is important. So what's good for the clitoris is good for, what's good for the heart is good for the clitoris. They're very similar organs, actually, vascular organs. So, or depending heavily upon good vasculature. So avoiding smoking, controlling weight, exercise, low carb Mediterranean diets, have a lot of fun, connect with people, train your brain, self-care. I mean, those things sound flippant. And if you're ever going to tell a woman with a sexual dysfunction, oh, all that you need to do is to go and train your brain, play a bit of Wordle, it's not going to solve her whole sexual dysfunction. But in the context of a healthy person, sexual pleasure is enabled. Of course, the psychiatric diagnosis has to be made. It has to be treated properly. It shouldn't be overtreated. I see so often menopausal women don't sleep well, and then they could get put on loads and loads of antidepressants. And if you just sort out their hormones, they sleep so much better. So don't use antidepressants and antipsychotics and anxiolytics unless it is necessary, but also don't undertreat because the psychiatric conditions cause sexual dysfunction. And then look at what's happening with all of the different hormones. And I'll go a bit into detail with that when we get to the intensive therapy. And then the other medical conditions, like, you know, if you have a patient on a beta blocker, they are not going to orgasm. If you have them on spironolactone for their blood pressure, it's going to make the testosterone zero and they're not going to become sexually aroused. Now we get over to legitimate information. So you have to affirm the possible impact of menopause and the medication and the surgical procedures and the medical conditions on their pleasure. Just mention it, that, you know, I'm putting you onto this, but it can influence your ability to experience sexual pleasure. And then if they have concerns, do not be dismissive towards their concerns. Respond to their concerns with, as a healthcare provider, you're ethically bound to this, scientific, evidence and rights-based, experience-informed information about sexual health and sexual functioning and sexual pleasure. So really, there is more than enough information out there. There's ample information out there. You just have to do a little bit moeite to make sure that you actually have access to this and you can share it with your patient, or send your patient somewhere where they can actually access it. If you read only one book about sex, this is going to change your practice. It's going to change your life. Read Emily Nagoski's Come As You Are. Emily Nagoski is a sex educator, but she reads current sex research. Believe me, I read sex research. I attend as many international conferences as I possibly can. This woman wrote a book based on evidence, but to the general public. That's hell of a helpful for healthcare providers as well. Come As You Are by Emily Nagoski. It talks about the dual control model, where all of us have brakes and accelerators. And menopausal women are experiencing a lot of brakes, but there are also a lot of accelerators that you can turn on, like giving them the right hormones, for instance, but also working on their context in which they have sex in other ways that could enable sexual pleasure for them. And this book teaches you how to do that. So you can refer patients. The Menopause Society has a great website on My Sexual Health. We've got something like 500 pages of information on there. The International Society for Sexual Medicine has extremely legit information on sexual health. You might have pamphlets that reps gave you that you can give your patients. There's support groups for menopause on Facebook. Sexual Pleasure and Facebook don't gel. But for menopause, certainly. And then at My Sexual Health, we have monthly free webinars aimed at the general public. But 50% of the people who attend our webinars are actually healthcare providers, because you know, we have such a lack of training in sexual health as healthcare providers in South Africa, that just coming to a webinar where we talk to the public about sex and menopause, for instance, healthcare providers also learn a lot about it there. So you have to make sure that your sex resources are sex positive. If it's not sex positive, be careful. You know, even in religious people, you have to have a sex positive outlook and not sell sex as something negative and, you know, for men and like, oh, thank goodness we don't have to do that anymore now that we're in menopause kind of thing. If that's your personal attitude, you're going to sell a sex negative attitude to patients, and then they have a right to pleasure. So you're going to hamper that. specific suggestions. So now we get to the more interesting things, and I actually want to stop sharing because I want to show you my stuff. So a lubricant for a menopausal patient. So to buy like a normal KY, and then you actually have to unscrew it, and they've got arthritis and it's becoming more difficult, and now you've already got going, and now you use your dirty hands to unscrew. Yes, we're beyond that. So give your patients a lube like this. You know what I'm going to do? I'm just going to stop blurring my view, because I do that now. No.
I think it's under
Yeah.
apps. If you look under apps, it should help you there.
Apps there, I can unblur my background, but then you're going to see my bedroom because my kid is watching TV, not to listen to this webinar in the office. So virtual backgrounds. I just want to, because when it's blurred, then you can't see the stuff very nicely. Now it wants to give you travel backgrounds and stuff. Okay, I'm just going to leave it like this. So if it's water-based, let it be in a top like this. This is beta gel. This is your order through Transform. So the pure range of lubricants is, if you've ever used a silicone lube, you never go back to water-based lube again. Why? The academics behind it is silicone adheres to the mucosa. So water-based lubes sit there, and if it has the wrong osmolality, it actually draws water out of the adherent tissue, and then it dries out and it becomes sticky quite quickly. Whereas a silicone adheres to the mucosa, so it protects the mucosa, plus then it is much more slippery than a water-based lube. So a bottle of lube like this costs 480 Rand, but it lasts a menopausal woman at least 6 months. It's really worth investing in that. Then this is one that contains hyaluronic acid. So it's a water-based lube, but with hyaluron. It's the Pure Med Repair. So it contains hyaluronic acid inside the water-based lube. But this Hydra V is formulated with hyaluronic acid in it, and it's a vaginal moisturizer. I really think that we've been needing a product like this in South Africa for a long time. So those patients that do not want to use a local estrogen for whatever reason, or can't use a local estrogen, this is a great vaginal moisturizer with hyaluronic acid. Lots of evidence about hyaluronic acid. I still would prefer hormones. I think hormones keep a pelvis much healthier. And I actually think the one hormone that we really neglect in the urogenital area is testosterone. A woman's, you guys are real experts in this area. I don't know at your conferences if there's so much research about testosterone's effect also being presented. Just out of interest, Prof, do they talk about at your conferences about the impact of testosterone on the urogenital tract?
Not at the Urogynec conferences, actually. I think they are still quite stuck on the estrogens. So, but I think those conferences are very, those are obviously very, focused on the testosterones. But
there's ample evidence. Obviously, I don't attend conferences where they talk about prolapse primarily. I attend conferences where it's a sexual medicine conference, so they talk about dyspareunia and that. But testosterone, it plays a vital role in the health of the urogenital tract, especially from a sexual perspective.
Well, I suppose it's something that we need to look at, and especially in the patients who not only have sexual dysfunction, but also, the other pelvic floor dysfunctions, recurrent UTIs.
Yes.
It might be a very good thing to look at. And I don't think that it's got any attention from that point of view at all.
One of the problems,
it's magic for recurrent UTI.
Yeah, one of the problems, recurrent UTI, there's estrogen, that helps. But one of the problems about testosterone and DHEA is they're off-label use. And number one, the medical aids won't touch anything that's off-label use. And patients and some doctors and practitioners also loath to use something that's off-label use. Now, the minute that testosterone gel is no longer off-label, I know you get it. It's available over here as testosterone.
Yes.
Gel,
but that gel, the androgel that's available, you cannot bring close to genitals. Yeah. Okay.
Yeah, well, it's off-label, and the same as DHEA, it's also off-label.
But now we're talking more about DHEAS. And etc. for vaginal use, because you wouldn't put tested gel.
You wouldn't put one in the vagina?
Gel. I mean, you wouldn't put that on the vagina.
Okay.
No, you can't. You can't. So you need to compound it. But look, as a sexual health physician, I 80% of what I prescribe is off-label. So I'm very comfortable with it. My patients all sign consent for off-label treatment. But yes, if you are the kind of doctor who never ventures into using anything off-label, cool, please don't, because you need to be really well informed to do it, and you need to be confident that this is really in the best interest of your patient, and obviously inform the patient of it. So then refer for that. But look, the evidence for the safety of testosterone in women is it's overwhelming now, and there's an international consensus statement by the International Menopause Society, International Study for Women's Sexual Health, the Endocrine Society. They all came together, 5 different societies, and made a consensus statement on the safety of the use of testosterone in women, obviously within strict parameters and with people who know what they're doing, but it is safe.
And
Okay,
can I just ask a practical question? We're very fortunate here
Sure.
in the Western Cape, in fact, in Cape Town, that we have access to you, because you're based in the northern suburbs. You're based in Durbanville, aren't you? Or in
I'm
Somerset?
in Stellenbosch. In Stellenbosch.
Okay, northern suburbs.
Yeah.
But are there people like you in the rest of our country, like
Yes.
northern, eastern, western?
So we also have a licensed sexual health practice where there's a doctor that works in Johannesburg and in Pretoria. And then our team there's a doctor in Nelspruit, and there's a physio in Bloemfontein, so all throughout the country, there are people that associate with my sexual health. If a person has seen a gynecologist, we can sort out most of their sexual health concerns online. A person who has dyspareunia and then wants to see me as their primary person online, that's obviously a bit dodgy, because they need to have a good physical examination. But someone who has a gynecologist well, preferably a gynecologist who has done a proper examination on them and excluded the major organic causes or the most obvious organic causes. There's always organic causes, always, but the most obvious ones, then there's not a massive ovarian tumor pushing a nerve that is causing the pain, then we can actually sort it out online as well.
Okay.
There's a quick question here for you. What is the cost of PGER with hyaluronic acid and then hyaluronic heel repair?
These are probably all around 480. If I'm not, the pure women and the hyaluron is around 480, I would guess. But the hyaluron one is not with silicone, it's with water. This one is 580, pure med. And for you guys who deal with a lot of recurrent UTIs, you do not want a patient to put a glycerine-based thing near their vagina. That glycerine is a substrate for bacteria to grow in. So these things are 100% pure silicone molecules stuck together. So, you get so much marketing about lubes having, it's all natural, but there is so much going on in that lube. They infuse it with things that really can irritate the mucosa of the vagina. So I like single agents. So that's why I like this Hydra V, where it's a hyaluronic acid, or then the silicone that's a single agent, because then if a patient also has a reaction to it, you know exactly what it is. But this thing, I can tell you, in all my years, I've never had a person who had a reaction to this. This is a fantastic lubricant, and so they pay $580 for this, but it lasts them 6 months or longer. Well, if they're having sex 6 times a day, then it's something different. I just have to show you something. You know what's one of the best sellers on our website at the moment? This thing, cannabis intimate oil. Women are going crazy for it. I don't know why, because as a healthcare provider, I would never promote it. I've never told a woman, oh, go and get a cannabis thingy, but they like that. And then this is something that I use frequently for menopausal women, Eucerin's Aquaphor. Because I don't know if you guys ever use Aquaphor. It's a wonderful product. It promotes healing and it's antibacterial. So those women who sometimes tear at the back, obviously you want to treat them, you want to re-estrogenize them, but if they tend to tear there, they put some of this on prior to penetration. So that then is like a Vaseline kind of thing. and it makes just a much thicker barrier. And then they use a silicone loop over that, or if there was a small tear, it heals much quicker when they use Aquafol. And then this is something that, you know, women get bladder infections after sex frequently. And I don't know if you know this product called D-Manos. Where is it now? D-Manos. I guess you guys use it for, or patients often use it for bladder infections. So why I find D-Manos so valuable is, it's like, for those of you who don't know D-Manos, it's like cranberry for UTIs on steroids. But if they tend to get a UTI frequently after sex, first estrogenize that pelvis. You need to, the estrogen is very important, but then the D-Manos just prevents the bacteria from adhering to the bladder wall, so they urinate it out. So they take this D-Manos 2 scoops before they have sex, 2 scoops after sex, 2 scoops when they wake up in the middle of the night, and then they don't get UTIs. It works like a bomb for the sex-induced UTIs that patients get. And this thing is called Cookie Fresh. I mean, it is the most ridiculous name that I've ever come across. But what's in here is billions of lactobacilli. So as you know, in menopause, women lose their ability to maintain their natural pH. And it also contains boric acid. Now, I don't know if you guys come across Candida glabrata. I see probably 5 Candida glabrata a year. And you know, the only way to treat that is with voriconazole that costs between 7,000 and 11,000 Rand. That's how to treat Candida glabrata. But with boric acid, you can actually treat it. And it's the first time that we now have a product in South Africa that's off the shelf that contains boric acid. So I think that's quite nice for, I mean, the right menopausal patient, of course.
I know you can also buy that from your that local pharmacy around the corner from you, the compounding pharmacy. They do have that boric acid suppositories, pessaries.
Yes, they have. But the way that this is, I think, I mean, that's what I've been using for a long time, but I think this is a much more patient-friendly approach than what we've been managing to compound.
Yeah. So I'll just ask you, someone has asked about, you know, how much are the gels, you know, if someone wants to go and buy a silicone-based gel from Dis-Chem or Clicks, which one do you recommend? Is there something like that also?
Or is it on your website?
You can, yeah, on My Sexual Health, all these products are available there. Dis-Chem and Clicks, they now and then have a silicone product there. But I haven't often seen a silicone product in Dis-Chem and Clicks. And if they do, just, I mean, if you have a vagina that can tolerate anything, that can tolerate pina colada lube, then you're probably okay with a Dis-Chem silicone. But the patients I see come to see me because they have really serious problems in their pelvis, and I will not tell them to go and use something that also contains parabens and all kinds of other chemicals on top of the silicone. So that's what makes it a bit cheaper, is that they mix the silicone with all kinds of other things, whereas if you read at the back of these things, it's just the silicone molecules. That's all that it is. So that's why I prefer this. And you know, the difference between a 320 lube and a 480 lube, for some people, it's everything. But for those who can already afford 320, it's not that difficult to go to 480 from there. And as I said, it lasts forever. Look, I do have a few slides left, but I just want to show you a few vibrators, because if you're ever going to see vibrators in a medical talk, it's today. So let me just show you a few. The ones that I recommend to most patients, if they need a vibrator for anorgasmia or just for pleasure, is just this one. It is 180 Rand. 180 Rand, so easy, a tiny little clitoral vibrator. And this is what this is. It's small, if you can, there's the actual size of it. It's not intimidating, doesn't look like a penis. The husband doesn't feel threatened by it. This thing, I just sold one to a patient, or not me, like my receptionist, a walk-in patient, that this thing, I mean, it's massive, and it's 5,000 Rand. So it has a G-spot stimulator there, and this is a clitoral stimulator, and you put it in together, so it does both at the same time. This is much more intimidating. Your average menopausal patient doesn't have to start with something like this, but sometimes they're interested in it. This is quite a nice vibrator. It's from Smile Makers, and it mimics oral sex. And remember, the most reliable way for women to orgasm is through oral sex. So because this thing vibrates, but it is such a soft thing like a tongue, it's quite a nice vibrator. Women who really struggle to orgasm in menopause, you want to go for something like this. This is a womanizer. So it also, in a way, mimics oral sex, but it has a very strong suction here. Not an entry-level vibrator at all. It's too strong. It's quite intense, but it mimics suction. And you know, this, like an entry-level one, is about 1,800 Rand, and the expensive ones are 4,800 Rand. So there's ranges of vibrators. Okay. Oh, and then let me just quickly see.
Those are all available online on your website. Those are all available.
But you know, I mean, we're not I don't go out to have a pleasure a website. The website basically just I started from my practice, because when the patient is there and I tell her, go, this pure comes from Germany, you know, the dilators we import from America, and then they just don't get all the products that they need. So that's why we started selling them. These dilators we now manufacture in South Africa. They are just under 2,000 Rand a set for a full set of dilators. Many women in menopause who've had cancer, or who've had lichen, or neglected atrophy, need vaginal dilators, and they can buy them in a full set, or they can actually buy them individually. And this is a nice one that you can actually get the stub dilators as well. They're short and they are more flat, so they can sleep with them at night. And they go to very big sizes. Most men are between a size 4 and 5, but I see the women in my practice that I need to use Botox for their sexual pain. Their partners are usually between number 6 or a 7 or a 7.5 even. So those patients with really big partners can actually train with dilators to stretch the vaginal opening without causing trauma. And then I just want to, well, we've got a nice online course that's quite cheap, how to have more fun in bed, which is something that you can easily refer a patient to. And then I just want to end off with, I probably still need to talk about how to treat it, but this is a very practical tool for yourself as well as for your patients. You do not need a massive vocabulary to be able to enhance your sexual pleasure repertoire. You need only these words. But what's important is that you get out of the idea that sexual pleasure is given and received at the same time. That's a very heteronormative, old kind of way of looking at sex, where you go like, oh, okay, while I am moving in and out, I must get pleasure and you must also get pleasure, and that's the be all and end all. What we say is, no, tonight I am going to pleasure you. And we're going to explore ways for you to experience more pleasure. And yes, of course, I'm also going to experience pleasure by giving you pleasure, but we focus tonight on your pleasure. So what you need to do then, please, is just use these words to instruct me on how we can increase your pleasure. And those words are only harder, softer, faster, slower, up, down, left, right, deeper, and stop. So the patient that I spoke about earlier, that the partner puts the finger in the vagina, she really enjoys oral sex, but she needs to be very aroused by the time that she receives oral sex. Otherwise, she finds it disgusting, which is a whole lecture on its own. But so if they were doing this, if they were only focusing on her pleasure, and he started right with oral sex, all that she would have done, she wouldn't have said, I don't like it when you give me oral sex, or I don't want oral sex. Now, all of those things are very negative, and women very seldom actually have the power in the relationship to say that. And it causes a lot of friction in the relationship if you have to say something as frank as that. I mean, you should be able to, but it's usually quite hard. So if you were playing this game, she would just go up. So he starts with oral sex and she just goes up, 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 until he gets to an area that she's more comfortable with. You know, so it's a very positive way of actually giving your partner positive feedback. And in that way, both of you learn what is pleasurable. It's so simple. And this is something you can explain to a patient in 3 or 5 minutes, but only when you have already gone through that permission thing and they've now, you know, said that they have a problem with pleasure. You can tell them to go and practice this at home and come back a month later and tell you how it went, because then they will come back and say, no, but you know, whatever the problem is, then it's amplified, and then you can take it further or you can refer. So for the intensive therapy, basically tibolone is a great choice for menopausal women because it's actually the only way in South Africa that you can legally activate the androgen receptor. So I really think if your patient can nearly afford it, it's a great place to go to. Transdermal estradiol, oral estradiol can and the more synthetic it is, the more it will raise SHBG. When SHBG gets raised, free testosterone lowers, and many women do become symptomatic from low free testosterone. And then, as I said, it's definitely internationally acceptable, evidence-based to give women testosterone, but it is off-label and you need to know how to do it. There's lots of confusion about measuring. Look, you have to measure testosterone. Where the problem with measuring comes in is you don't just go and test every single menopausal woman's testosterone and go and put all those with low testosterone on testosterone. It doesn't work like that. The woman first presents with the symptoms. She tells you she can't orgasm. She doesn't become aroused. She's lost all interest in sex. Then you say, you know what? Almost all women lose their testosterone in menopause. I'm just going to check whether it's the case in you. Oh, okay, you have a testosterone of less than 0.4. Let me give you a little bit of testosterone. And then 1 month later, check how your body responds to this compound. Because I can tell you from the evidence of my practice, having prescribed thousands of testosterone prescriptions, 1 in 10 go into male ranges. It's a lot. It's a lot. I mean, if you had a 10% complication rate in a procedure, you would be careful. So you have to monitor levels. So there was a lot of said about don't monitor levels, but that is because there isn't a great correlation between low levels and sexual dysfunction. Many women with low levels don't have sexual dysfunction, if that makes sense. But yes, I treat it. You can give PD5 inhibitors off-label to women if they have a specific local, they have a problem that they don't feel aroused in their genitals. PD5s have some positive effect. Bupropion has great effect, but many menopausal women are anxious, so you can't give them bupropion. And then physio, I believe in physio like the Bible. It does wonders for sex, and specifically menopausal women. They often are hypertonic or weak, which can both influence their sexual function. And then the regenerative therapies, there's some evidence coming out, but I think we have to look at the ethics of it. We don't sell, oh, come for a lunchtime laser, it's going to improve your libido. That's absolute nonsense. But there is some space for it now. I mean, you guys are experts on that, but you know, I'm worried about it being out of the hands of experts like you, in the hands of beauticians who sell it as a way to treat low libido, which is nonsense. And then please refer patients with a history of sexual abuse. That needs to be seen not only just by a normal psychologist, by a psychosexual therapist. If they have low scores on that pleasure meter, you know, the consent, or they're unsafe or something like that, refer them to get professional help for that situation. Any person that you're uncomfortable to stalk, you know, let's say it's a person that's a throuple and they from your religion, but they're a throuple and you're feeling very uncomfortable with that, anything like that, refer, or all patients who ask for referral. Sex coaching, body work, like actually touching patients and helping them to have orgasms in that way. And sex work is, of course, completely outside of the scope of healthcare providers, and that's not what you will find if you refer to my sexual health provider. But some people do see that there's a place for that. So some of your menopausal women might be seeing a sex coach or a body worker going for sensual massages and things. So, I mean, it exists, but it's not within the scope of healthcare. And I think I've given lots of take-home messages. So I'll conclude it there. We have a World Congress coming up in November in Antalya. If you want a hell of a lot of fun, come to a Sexology Congress at a resort, an all-inclusive resort in Turkey. It's not a hell of a lot of fun in the way that you would think. I mean, everyone there is very ethical, but it is really fun to be around a bunch of sexologists. And there's my contact details. You're welcome to contact me. And if you refer patients to the website, through the website, they get to the right person on our side. So, yes. That's
well, thanks so much.
From us.
Yeah, we really enjoyed that. I mean, we really learned a lot, and a lot of good tips. And there is one extra question here from Moira Stein. Your opinion on Astroglide? It's commercially available, I think, in some of the pharmacies, etc.
Yeah, so Astroglide also, it's not pure, you know, well, it's not pure. It's not there. If you, I can't remember exactly what it contains, but I looked at it recently because it is, and the Uberlube, and I mean, and look, I don't want to cause harm companies, but I think Astroglide is already quite expensive, and you can just for a little bit more money get a much better product. Many vaginas can take just about anything, but like as you guys see in your practice, you treat very special vaginas, and you do not want them to put something in there that contains a lot of chemicals.
No, look, I agree with you on that, and I think it is time to just get the patients the simple the silicones. It doesn't seem like it's a lot more expensive, and I'm certainly going to start trying that myself, because I don't think those commercial things, I haven't heard good things about them. I mean, maybe Moira, you have, but I think it's probably time to look at some more simple based things.
Talking about time, Steve, sadly we've run out of time, and I'm
absolutely.
getting dug in the ribs by a car in here to say our bandwidth is expired. Would you mind thanking our speaker?
Yeah, well, I mean, I already have, and I mean, look, it's been marvelous, and thanks for the ideas, thanks for the enthusiasm with which you presented, and really given us a lot of great ideas. This is something a little bit of a heart sink for a lot of doctors when patients bring these issues up, but there's a lot of help out there, and thanks for showing us. Yeah,
thank you, Elna. Very, very kind indeed. And just to remind everybody that we've spoken about menopausal therapy and vaginal testosterone. Next week, we have Dr. Percy Moodley, who's the president of the Menopause Society before Malika, individualization of hormonal therapy in the menopause. So this is something that, for those of you that want those specific questions, Percy will be able to answer these questions next week. So on behalf of the Pelvic Floor Foundation, a great big thank you to Astellas, who are the sponsors tonight. Safe home. I hope you can get home before the sun comes up because of the taxi strike. It's been wonderful seeing Elna, and a great big thank you to Cara. Thank you very much indeed. Good night.
Great. Thank you very much.
Thank you. Thanks a lot.
Bye.
Bye.